Good morning, everybody. Thanks for the opportunity. We've been planning this grant rounds for a while, and COVID, of course, delayed us. And we're very happy that we have the opportunity to do it today. So welcome, everyone. We're just going to present our program and give you a few updates on basically where we're heading, what we've done also, and try to share some of our successes as well in our program and some of the things we also have challenges with. So we're going to start by discussing a little bit about facts about pediatric and adolescent obesity. Then we're going to describe our program. And then Janey's going to take it on to discuss the new guidelines and indications and what kind of innovations we've been working on in our program over the past 5 years, as well as discussing the current and future scholarly output. So obesity, as everybody knows, is a pandemic, 400,000 deaths per year, and children are the fastest growing segment of the obese population. And that's the part that's sort of fascinating to us in a bad way, of course. It's usually refractory to conventional methods of weight loss. Once you reach a certain BMI, it's very, very difficult to lose weight. And not only that, it's very difficult to maintain a lower BMI because it's very easy just to recur and go back to severe obesity. So many of the papers for years now have shown that surgery is the most effective method. And unfortunately, there's no other effective ways of treating this disease once we get to the severe obesity component, giving to very high BMIs. Now, there's this misconception that little children, when you see them and they're a little bit round, sort of bigger than the rest of their peers, or they're obese at that age, many parents think they're going to basically get slimmer as they grow older. They head to teenage years and they're going to stretch, and in adults, everything's going to solve. But actually, it's the complete opposite. Children that have a very high BMI at 10 years of age will become obese teenagers and will become obese adults. And that is the sad part of the story. These things have to be taken very seriously, and we really need to educate our young children as they become adolescents that this, unfortunately, the progression is that these patients will be severe obese patients towards teenage years and adulthood. This is just to show that from the top down, obesity will bring a lot of comorbidities. No matter how you look at it, it's going to make pretty much everything worse, including COVID. So that was one of the highest risks for mortality from COVID was obesity. So it is a very severe problem. I'm just going to focus on some of the comorbidities to give you an idea on what weight loss surgery will do. So for type 2 diabetes, a third of healthy toddlers are at risk for developing diabetes, and it's very high in the Hispanic population. As you know, medical treatment shows very poor response, and metabolic surgery will completely reverse diabetes. We'll show you some data later that show that, more than 90% of these patients get off medications and their diabetes gets cured. So this is a strong indication for metabolic surgery. Same thing with sleep apnea. It does affect many of these patients, and these kids have a lot of trouble sleeping. They're tired all day. They have learning difficulties. They're in a bad mood. They are not compliant. And as you can imagine, that snowballs towards poor performance and, of course, many other comorbidities. And we've also seen that metabolic and bariatric surgery will reverse this in many of these patients. So it's also considered a strong indication for surgery. NASH is another one because almost all of these patients will have a fatty liver, and NASH is seen in about 2/3 of the patients that could very easily progress to cirrhosis if it's left untreated. The good thing is that by losing weight, this process is completely reversible if we're short of fibrosis in the liver, and it's also considered a strong indication for surgery. Pseudotumor cerebri, even though it's not very common, we've had a few patients that have this presentation, which is terrible. These patients struggle a lot. They have these severe headaches with blurred vision, nausea, vomiting, all sorts of discomfort, and it really acts as if you had a tumor in your brain just because of severe obesity. And by losing weight, all these symptoms go away. So it's another strong indication, in our program. And cardiovascular disease is a little bit hard to prove because they're still very young, but these curves clearly show that your increased BMI during adolescence will lead to increased risk of dying from heart disease as you grow older. So it's also a very strong indication. So when we see these patients, depending on their BMIs, and we'll talk about this later on the numbers and the indications, but when these patients have comorbidities, there are candidates for surgery. And in some cases, we have to move them up in our program because their comorbidities are so severe that they just can't wait months like this because their performance and health gets affected significantly. So to summarize, dietary and behavioral treatment for severe obesity unfortunately has a high dropout rate, poor compliance. It's just not successful overall, has high recurrence rate. And more than anything, all these programs are not covered by insurance. So it ends up being more expensive at times when you compare it to surgical therapy, which is the most effective at long-term weight loss and resolution of the comorbidities. There's more for our trainees. The operations for metabolic and bariatric surgery are basically 3 these days, which is the Gastric Band, as you see here. I stole these pictures from Janey, which are beautiful. So thank you very much. The Gastric Band was very popular, and actually was very popular in other countries as well for the treatment of severe obesity. It's not approved by the FDA for adolescents. It's sort of a high maintenance procedure, even though the operation is fairly quick. And it is just not well suited for adolescents with a foreign body and several adjustments, and clearly it's not approved. So we of course don't do this operation. The Runway Gastric Bypass, as you all know, is gold standard in adults, and it's been like this for many, many years. And little by little, the sleeve gastrectomy is sort of the percentages of procedures, even in adults, is being higher than the gastric bypass. The gastric bypass is a very effective operation for losing weight. It basically consists of creating a very small gastric pouch and bypassing a lot of the intestine. I mean, you don't see it in this picture, but many, 100, 150 centimeters get bypassed, and the malabsorption is quite significant, and these patients lose weight. But we don't feel it's the best option for adolescents, basically from the malabsorptive perspective of the procedure. These kids are all growing, they're developing their brains, their muscles, their bones, and it's not a good time to be deficient in nutrients. So the sleeve gastrectomy is the one that feels the most attractive, and I'll tell you why. It did start as a first stage procedure in very high risk patients, these patients with massive BMIs that couldn't lay on the bed for long and tolerate a gastric bypass. These patients would get staged with a sleeve gastrectomy, and then saw that in the long run, they were having significant weight loss and not necessarily needed the second stage, which was the gastric bypass. It really, most people think that the restrictive portion of the procedure is what's going to make you lose weight, but actually it's the least important. The most important is the metabolic change that happens as you remove the fundus. Number one, because you decrease the production of ghrelin, which is the hormone that controls your appetite. So these patients, their appetite decreases significantly. The other thing that it does, your gastric emptying now, it's faster. So patients will feel full very quickly after eating, and the release of hormones at the duodenal aspect of the GI tract will also control your insulin resistance, your satiety, and all sorts of metabolic changes that eventually lead into weight loss. There are no anastomosis, there are no mesenteric defects, there's no room for vagal injury or foreign bodies, and that's why we all feel it was very attractive for adolescents when we started doing it many years ago. And the good thing is that as they grow older, if their weight gain recurs, it can be converted to a Runway gastric bypass in early adulthood. So you're not burning any bridges, and you're really setting them up for success if they're in a sort of a contained program that can help them with a very tight follow-up. So our team, as you see here, is very big. We work very hard in order to try to clear these patients to undergo an operation. We really want to find those patients that are going to be successful, because about 1 in every 5 patients won't lose weight, or at least may lose weight initially, but will gain it. And this is hard to explain no matter how hard we try, but it does have a lot to do with their environment. So we take that very seriously. And we do have a multidisciplinary team approach that includes pediatric obesity specialists, surgeons, dietitians, psychologists, adolescent medicine, and now we've incorporated more subspecialties into our board like GI and cardiology. And of course, we have our social worker and our program coordinator that, that of course, you know, look at the environment of these patients and help us coordinate treatment. We were accredited by the American Society of Metabolic and Bariatric Surgery, which was a very important time in our timeline, because we're the only accredited program in the West Coast and one of few programs that are accredited in the country. So it really has become a destination program. We get patients from all over the state and also out of state. So we're very proud of that. And just to tell you a little bit of the history, Craig Albanese and John Morton started it in 2006. And at that time, operating on these children was not very well seen. Mostly by pediatricians and many surgeons, of course. It was sort of a very unusual procedure to perform. And we had all these misconceptions that things were going to get better, and actually things kept getting worse. So the volume was very low. We were doing about 1 or 2 cases a year. As we kept growing the program, we finally got accreditation in 2017. And this really helped us more than anything with insurance approval. And once you get accreditation, also, you know, the disease became more obvious. The epidemic became more obvious, and the general knowledge of the public and healthcare workers started to understand that it was the only way of losing weight. So our volume went up. And like Mary was saying, we're very lucky to recruit Janey. Janey has a really deep passion for this disease and how she treats these patients, and really helped us take the program to the next level. Our volume, you know, grew significantly. We organized our outpatient clinics, our referral pattern. We started, you know, at that time when we were starting the program, we were waiting for the pediatricians to refer the patients, but unfortunately their infrastructure was not as robust in the outpatient setting because they were just so busy with the general population. So we switched that and we started making surgery the initial step to evaluate these patients, and of course include our multidisciplinary board to help us decide who's going to be successful. And now we've been doing about 35 cases a year for the past 2 to 3 years, and we are still growing. Our clinics are extremely busy, and we've been scheduling surgeries pretty steadily, thankfully. So just a little bit of logistics of the program. We do offer a bariatric teaching session every month, both in English and in Spanish. So it's 2 teaching sessions per month. That's how the patients get introduced to our program. And then if they're interested, they formally sign up, and they have a 4 to 6 months evaluation process that includes multi-specialty evaluation, discovery of comorbidities, starting to treat these comorbidities, and get them through the process of understanding what the operation means. These clinic visits are happening exclusively via telehealth, and that's, again, another of the sort of advantages of COVID, if you will. We really switched that, and actually it's become much more efficient. And Janey will discuss this a little bit more, but we started doing all these group sessions that helped the efficiency of the program, and we're able to catch more patients and be able to see patients in a less amount of time. And we do meet every month, all of us, and we run the patients, and we talk about some research ideas. We talk about what's, you know, patients are trouble, who needs to be cleared, and decide on that basis who's ready for the operation. Let me tell you a little bit about what we've done and what the country and the world have done to show that bariatric surgery in adolescents is a positive thing, and how these patients get benefit from it. We published our data on 38 patients. This was right when Janey was joining. So we, our numbers are not great, but we really grew significantly after that. The mean age was about 16 years. And as you see, most of our patients are Hispanic. So it does affect low socioeconomic status. You can see from the insurance, 47% of this is public. As you can imagine, this is a challenge with the hospital in order to get support, because we do have a payer mix index that, of course, doesn't help us. And you can see here the comorbidities that we talked about: diabetes, hypertension, NASH, sleep apnea. They were all there. Our weight loss at a year was very satisfactory, as you can see here on these percentages that are highlighted. And the other important thing was that, as you see here, diabetes, for example, in 11 patients, 10 had resolution. Hypertension, all of them got resolution. Dyslipidemia, NASH. So that was the eye-opening finding for us, is that we weren't getting them back into tight genes, but we were really resolving their comorbidities. That's basically what's going to affect them as they grow older. And that's what really showed us that we got to keep fighting and we got to keep doing this. And not only that, we have to do it as early as possible in order to help these children. Around the same time, this multi-center study was going on that was published in the New England, which was sort of our landmark study, because it is the largest study. It studied 240 patients. And it basically designed to assess the safety and efficacy of metabolic surgery in patients between 13 to 19 years of age. And you can see the median BMI there, which is it's extremely high. And as you can see, they compared sleeve gastrectomy with Runway gastric bypass, and the weight loss was very similar. So that was very encouraging. And not only that, same findings we had, the resolution of the comorbidities was very significant for diabetes, dyslipidemia, hypertension, and renal function. So these 3-year remission rates were also very eye-opening and sort of revolutionized the way we care for these patients. And Janey will talk about this too, how the society started to embrace this and own it. Another important study is the comparison of how we treat diabetes, either medically or surgically with metabolic surgery. And as you can see in these graphs, the reduction of the A1C, the improvement in insulin resistance and in triglycerides, and the less amount of renal injury was seen in patients that underwent surgery compared to medical treatment. And not only that, these patients that were operated on had much higher BMIs than the ones that were treated medically. So it is quite the finding. And just to finish, before we switch back to Janey, this is a comparison of adult and adolescent sleeve gastrectomies at 4 years. And you can see that the adolescents had a higher BMI, adolescents had less comorbidities, which makes sense, but still were pretty sick. And they had a much better weight loss in percentage and resolution of comorbidities when compared to adults. So we do think metabolic and bariatric surgery in adolescents is here to stay. It's going to get, unfortunately, more popular because it is a pandemic that's growing. And I think we have to educate our patients. The earlier, the better. And if they get comorbidities, the earlier they get the operation, the better. So thank you very much. I'll stop sharing. And Janey, I'll pass it on to you.
So I'm going to do the second part of the
adolescent. You're all good, Janey, there.
Thanks. Adolescent Metabolic and Bariatric Surgery Updates and Innovations, part 2. So when I first came to Stanford in 2017, I was working on the ASMBS Pediatric Metabolic and Bariatric Guidelines update from 2018. I've been writing guidelines since 2004 for pediatric surgery, but this was really the first one that I had authored and led the charge on, and Matias was helping with it already on a national level. These guidelines made a lot of changes. So what we tried to do with the guidelines was remove the barriers to surgery. There were lots of barriers in the older guidelines. For example, there was this barrier saying that they needed to have a preoperative diet, that they had to have tried multiple attempts at losing weight. And the fact is there was no data to show that that made a difference. There's all kinds of things about letting kids reach a Tanner stage, and there was also no data showing that surgery would delay development or delay reaching a Tanner stage. There was data on bone age, and the only study on bone age actually shows that there was improved linear growth after surgery, which would argue that you should do surgery before they reach a certain bone age, as opposed to after, which were the previous guidelines. And in the new guidelines, we actually decided to state an age because we felt that patients were not being operated on young enough, and they were waiting until their BMIs were 60 and 70. We really wanted the children to come in earlier so that we could catch them when their BMIs were lower. So we actually used the World Health Organization definition of adolescents and said you should operate on kids between the ages of 10 and 19. And you'll see later in the presentation that that's all changed now too, since 2018. So this is a rapidly changing understanding of the disease. But the basis of what we base all of our teaching on and all of our research on is that obesity is a disease, and that delaying surgery only leads to higher BMI and more comorbidities. And if you use that as your basic tenet, you make all the right decisions along the way. So we also removed a lot of contraindications. We removed the contraindication of depression as long as it's treated and stable, of eating disorders, again, as long as they're treated and stable, because there's no indication that these patients have worse outcomes than those who don't suffer from these other diseases. There's no indication that a history of trauma, that an unstable family situation, that autism, syndromic obesity, or developmental delay lead to worse outcomes. So all of these were removed as contraindications to surgery. We also removed that children were unable to assent to surgery. So our feeling was that if a child is well supported at home, if they're unable to assent, we asked the ethics committee to get involved and to assess whether that child would benefit from surgery. And we've done several children with developmental delay. I'll talk about that later. So one of the biggest changes in the new guidelines was the BMI cutoffs. So in the oldest guidelines for adolescents in 2004, 2005, the cutoffs were higher than for adults. So we would say a BMI of 40 with comorbidities or a BMI of 50. We dropped it down to match the adult guidelines in the 2012 guidelines. And then in these guidelines, we decided to switch to use the growth chart. So if you use the growth chart, the definition of obesity in pediatrics is a BMI over the 95th percentile. So that's this blue line here. And the definition of class 2 obesity, which is in adults a BMI of 35, is 120% of the 95th percentile, which is this red line here. And then the BMI greater than 40, or class 3 obesity in adults, is 140%, which is this line right here, of the 95th percentile, okay? So you can see at age 18, these about cross. So we had originally used these cutoffs. Now we're using BMI greater than 140% of the 95th percentile. This is hard to understand, but this picture does come up in EPIC, so it helps us a lot. So for example, the children that we see are often kids who at age 9, in this case, had a BMI of 32, which was 143% of the 95th percentile. This child at age 9 would have qualified for bariatric surgery even without a comorbidity. We didn't see the child until they reached age 15, and their BMI is now 50. The problem with this is that when we do surgery, we usually, on average, lose about 15 BMI points. So 15 BMI points from here is actually down to a normal weight for that age. That's actually down to the 50th percentile. 15 BMI points here, this child will still have obesity. And so because it's really sort of a fixed weight loss in most patients, we're much better off if we can operate on them when they are younger and their BMI is lower. So the American Academy of Pediatrics actually recognized this, and they put out a policy statement in 2019 that says current longitudinal studies evaluating safety and efficacy endpoints do not apply specific age limits for the timing of surgery. Thus, there is no evidence to support the application of age-based eligibility limits. And this basically changed everything. What this means is that the American Academy of Pediatrics, which is a very conservative group, actually supports surgery at any age based on BMI. So once a child is diagnosed with obesity, they come into our program and they are eligible for surgery as soon as they have completed the program. So what they said is BMI, not age, should be used as an indication for surgery. And they define BMI again as class 2 obesity with a comorbidity, or class 3 obesity, not necessarily having a comorbidity. So this opened up bariatric surgery to a larger population than before. They also advocated very strongly for pediatricians to refer patients to multidisciplinary centers as soon as they diagnose obesity. So what's the Stanford program doing? We've been making lots of innovations, and we're basically trying to go from this old paradigm of lifestyle and diet changes, followed by pharmacotherapy, followed by a few patients would come to surgery, to a new paradigm of treatment where the patient comes in, it's family-based therapy, they are simultaneously considered for surgery if their BMI is either level 2 or 3, and they are simultaneously work with on their microenvironment. So we try to work on nutrient signaling, muscle activity, stress, sleep, circadian rhythm. So it's really a holistic approach. And we use pharmacology both before and after surgery. So basically it's a circle, and we go around it again and again and again. If a patient has metabolic and bariatric surgery, they don't lose enough weight, we add medications. If we need to, we go back to the microenvironment, we add medications again, we do another surgery as needed. And basically we continue to treat this disease as a group and in a multidisciplinary fashion. So what have we done to the Stanford program to head towards this model? The first thing we did is we went into a group program because we didn't have a lot of nutrition resources. We decided to spread those resources by having a 1-hour group meeting. It's designed to improve eating habits and activity. The participants set monthly goals. We were doing it in person, but we have now moved to Zoom meetings. And these have actually been very well received. The kids love them. They get to see other kids who are in their situation, who are suffering from obesity, and they really connect. It runs both pre-op and post-op, and it runs on a rotating schedule, so kids can join in at any time. They don't have to be in a fixed group of the same kids. We have 2 pre-op groups a month, and we have 1 post-op group a month, and then we have a greater than 1-year support group once a month. And we then, in 2019, we developed a new pre-op lifestyle intervention handbook. So our dietitians were wonderful. Beth Cotter and Jamie Saeed wrote a brand new book, and it has interactive projects, it has group projects, and the basis of our teaching is what we call the 60-60-60 rule. And this is a rule that basically says you want to eat 60 grams of protein, drink 60 ounces of water, and exercise or walk for 60 minutes every day. And we basically drill this into the kids so that they are prepared and they can remember, what am I supposed to do for the rest of my life to be successful with my surgery? And so this is the basic rule that we teach them. There's other things that we teach them, but this is the basis of it. We then transitioned in March 2020 to telehealth. And the teaching sessions went via Zoom. All the groups and other visits went via Zoom. And we basically did all of this we missed 1 clinic. So there was no delay in treatment anywhere along the way. Each patient was instructed to purchase a digital scale, which is about $30, a 30-ounce water bottle, and a pill box for AM and PM meds so they can remember to take their vitamins. We also have them buy their post-op vitamins, and we tell them that to get their calcium, the multivitamin, the sublingual B12, and the vitamin B1. And using the pill bottles and the water bottles, I think helps the kids follow the 60-60-60 rule and take their vitamins on a regular basis. In this year, we started in January a ERAS program. So in order to get kids, have them do better with the nausea and vomiting after surgery, which is the biggest issue with sleeve gastrectomy, we put them on a 2-week pre-op meal replacement diet, which allows them to shrink their liver. We then do a 20-ounce sports drink 2 to 4 hours before surgery with a dose of gabapentin and a dose of Tylenol. We have no Foley catheters or drains. Anesthesia uses minimal narcotics, and then they're heavy on the Toradol, Zofran, Scope, and dexamethasone to control the post-op nausea. We put in Exparel and bupivacaine tap blocks laparoscopically to help prevent post-op pain. And we don't do a post-op upper GI. We use multimodal pain management post-op, and then aggressive nausea management with Zofran, Ativan, and Reglan as needed. And then finally, we have early ambulation with PT, and we discharge on a 2-week liquid diet, which they've been trained up to. This is an example of one of our kids. This is a family that all have had bariatric surgery, and he and his brother have both had surgery in our program. We also have a quality improvement project every single year, and this is actually part of our MBSA QIP accreditation. So some of our quality improvement projects, just to highlight some, was first, we improved access to care by managing with direct referral to the MBS teaching programs. So our MBS teaching sessions in English and Spanish basically explain all of the programs available at Stanford. And so all of the Stanford programs are described, and we then encourage the kids who have a higher BMI to join the surgery program, even if they're not quite interested in surgery yet. Just having them come to the groups, it's the best program that we have in terms of group visits. And then we have the next year we did a nutrition patient survey to see what the satisfaction was with the nutrition teaching. This was before starting our new handbook. We then, in 2020, we worked with developmentally delayed kids and expedited ethics committee evaluation. And this has actually now been turned into an article, and Dr. Jones and Dr. Matias have just been accepted for publication. So we're very excited about that, looking at our experience with kids with developmental delay. We also now are currently working on a project looking at our no-show rates and cancellation rates after converting to a telehealth program, and wondering if this is going to allow for better access to care, because many of our patients come from 2, 3, 4, 9 hours away by car. Now they don't need to, and it's been actually very helpful to be able to see patients over Zoom. And then finally, next year, we plan to evaluate our ERAS program and see if our pain control, nausea, and length of stay have improved over our historic controls. So the Stanford Bariatric Program from 2015 to 2021 has published multiple papers. We're now up to 34, including the 2 that have just been accepted for publication. We're also seeing increased numbers of collaboration. So the orange represents where more than one person in our group is publishing. And you can see that now almost every publication that comes out of our group has more than one of us on it. So we're really collaborating a lot. We've started a new research meeting monthly that meets Tuesday afternoons. So now we're really moving into do more and more research. We've also noted that the teen labs, our group reanalyzed the teen labs data to look at outcomes based on age. So we took sleeve and bypass patients and we looked at 5-year outcomes, and we divided them into 13 to 15-year-olds and 16 to 19-year-olds with the same average BMI. And we found that there was an equivalent reduction in BMI. There was equivalent improvement in quality of life. There was equivalent resolution of comorbidities, and there were lower vitamin deficiencies in the younger cohort. So it was actually a very exciting study. This just came out, Matias and I co-authored, and it just came out in 2021. We also have 7 research grants, actually 5, and 2 are under review. We have an NIH grant under review, and we have an MHCRI grant under review. Thanks to the Department of Surgery for funding our JEDI seed grant to look at diabetes remission in Hispanic patients. We have an ongoing studies that I'll talk about in a minute, but all of our funding has come from the Department of Surgery, the Department of Digestive Health, and Stanford MCHRI, and now we're looking outside, again, NIH for funding. One of the best grants we have going is this great project, this MCHRI study project that Bmi Matias is running. And basically what she's doing is psychological testing for these factors, baseline, and then 6 months after surgery. And she's already accrued, I believe, about 10 patients that have been fully tested, and another several that have already undergone baseline testing. So we're very excited about this project, and we're going to try to find out if there are any of these functions or any of these effects have any effect on long-term weight loss. The Mab study is a project that Dr. Herdes and myself are working on, and this is looking at the use of medications after bariatric surgery. We have looking at all the kids in our program with inadequate weight loss, and it's early intervention. It's adding medications at 3 to 6 months if we're seeing inadequate weight loss. And we're still, this is funded by the MCHRI, and we're looking for further funding to pay for the medications. And then finally, we've started a database called COSMIC, which is Childhood Obesity Surgery Multi-Institutional Collaboration. And this is a collaboration between Harvard, Columbia, and ourselves, looking at all of the factors involved in obesity in children and how these are being treated. And we're very excited about this database too. It is about to go live, and then we will be entering the data. So, and continuing to collect prospectively. This is our team. These are all of the folks involved in the obesity program, and I just want to thank them all for their help along the way in the last 5 years, and we're really looking forward to continued work and continued growth in our program. Thank you for listening.